introduction. I have been given the responsibility to talk on multidisciplinary approach to hepatocellular carcinoma. The main theme of our organization, Bangladesh Society for Liver Cancer Treatment and Research, is the multidisciplinary approach for the management of hepatocellular carcinoma. So they have given me the responsibility and the beginning of the session with the first lecture on multidisciplinary approach to hepatocellular carcinoma. What is hepatocellular carcinoma? I have liked this definition. This is a very simple definition. Cancer that begins in the liver cell. Cancer that begins in the liver cell. এখানে বলি ঠিক আছে এখানে ঠিক আছে ইদেন নাই না কোথায় না এটা নেই স্যার আপনি চাইলে এটা দেখতে পারেন আচ্ছা ঠিক আছে What is hepatocellular carcinoma? This definition is very simple, and you see that cancer that begins in the liver cell is hepatocellular carcinoma. Most common type of primary liver cancer worldwide. Usually it develops in cirrhotic liver, but may also develop in non-cirrhotic liver. HCC is very complex and its management is very complex because tumor has different tumors have different behavior. We must take into account the status of the liver disease and the patient's health. And you can see that death rate is more than the incidence rate. That means it is a very serious disease. No single specialist can manage this, so a multidisciplinary approach will solve the problem. If one doctor approaches the disease, radiologists say, for example, radiologists may miss some findings and surgeons may not see all the options, but oncologists may overlook surgical signs. So the patient may lose opportunities for cure. So the combined effort is the answer. So I have already said that multidisciplinary team approach is the answer. What is multidisciplinary? What is MDT? MDT is defined as the cooperation between different specialized professionals involved in cancer care with the overarching goal of improving treatment efficiency and patient's care. In many research studies, it has been found that if we work with multidisciplinary approach, then we can, there is a good survival. In one of the study from Korea, it is said that with MDT, the 5-year survival is 71.2, and without MDT, it is 49.4%. And in a Taiwan study, it was found that the death rate was 12% lower with MDT management. What is the MDT team? Usually, when in a central place, we perform the MDT multidisciplinary approach. Then we can see we usually select 7 to 10 specialists working as one team. You can see all the experts are sitting together in a table and they are discussing about one disease. The disease is hepatocellular carcinoma. Here is hepatology, there is hepatobiliary surgeons, there is radiologists, there is pathologists, everybody is giving his opinion, and ultimately we come to a conclusion. This is a coordinated team effort. Hepatologist usually coordinates the whole process, and he gives his opinion, and he calculates the child power, male score, LV scores, and and he treats the patient. If the patient is suffering from HBV and HCV, he takes the responsibility. And in my country, though ERCP, PTBD, TASE, these are being done by the interventional radiologists, but in my country, we usually, the hepatologists, do this procedure in cooperation with the interventional radiologists. Hepatobiliary surgeon sees the patient. He decides about the possibility of surgical procedure, that is resection, or the possibility of transplant in this patient. Radiologist see, and he also determines the lesion, the size of the lesion, number of the lesion, is there any metastasis to other organs, or there is vascular invasion. Interventional radiologists, I have already said, in cooperation we do the procedures. Medical oncologists, they decide the medical treatment, say, we also cooperate with the medical oncologists about the treatment, TKI, immunotherapy, and they also plan, if the patient do not respond to the first line, they also plan for the second line of treatment. Pathologist determines the nature of the lesion, aggressiveness of the lesion, and the invasion of the vascular invasion of the disease, and they also do the immunohistochemistry to pinpoint exactly the diagnosis. Transplant hepatologists usually assess the patient, they follow up the patient, and they manage the patient after the transplant surgery. And all other persons, nurses, nutritionists, palliative care physician, social workers, psychologists, they also work together for the individualized decision about the patient and care of the patient. How MDT works? We usually either bi-weekly or a single meeting in the week, and that may take time according to the seriousness of the patient. Hepatologists usually present. Hepatologists usually proceed with the sum. No, hepatologist usually briefs all the members about the gist of the patient, its condition, its disease condition, and the patient condition and associated illness of the patient. And the radiologist usually gives opinion about the radiology, its invasiveness, its involvement in other organs, and we proceed discuss about the case. Surgeon, oncologist, radiologist all give their opinion, and the consensus is reached and individualized decision is taken. Why MDT makes better decision? Many experts catch what one doctor misses. Say, if you see, say a single person is examining the patient and manages the patient, there one doctor may make a mistake and he may miss some of the findings and patient may be deprived of the better management. So if combinedly it has been found that the error is reduced by 30% and resulted change in management, we have seen that there is in 65% cases, there is change of management and error is reduced by 30%. We consider all the factors of the patients and all the factors of the disease and available, and then we take the decision. In Bangladesh, what is the challenge? There are, you know that there are few specialists outside Dhaka, so MDT management, especially if we link with the internet and there is good facility and patient is benefited, especially by telemedicine. Challenge 2 is the imaging sources. You cannot find good images and good radiological availability outside Dhaka. So if you telecommunication interconnect with each other, the decision making is improved. Treatment cost, if you decide, if you discuss, and if you take the financial capability of the patient, then you can select a good modality of treatment and you can reduce the costing. And usually our patients are late presentation and this may be overcome by MDT, may take initiatives for building awareness through social campaigning. And there is loss of follow-up, and this is overcome by National Cancer Registry taking system for outcome. And if patient follow-up is missed, we may see the registry and we can call the patient over phone. What is solution? Solution is the MDT. In Bangladesh, we have selected 3 tiers. First tier, tier 1 is in the district hospital. Second tier is the division or medical colleges. Third one is the tertiary hospital. And in district hospital, you can bus very simply by one hepatologist, radiologist, and local doctors, and you can take the help of other specialists through internet. And in medical colleges, they can also communicate with the tertiary center, and the primary center, tier 1, may also supply information to them. So tertiary center, I have already said, the member of the team is 7 or more, and usually how they meet and how they discuss, I have already discussed this. And one tier may connect with others, and the information is better informed, and decision making is easier. What is needed to start a multidisciplinary team, conference room, and etc. All of you know that what is needed for a meeting. This is the case 1. This is an example that case 1, early HCC, 55 years old, 50. This is the case 1, for example. early HCC, 55 years old man, 55 years old man. Patient is 55 years, SBSAG positive, 3 centimeter nodule, preserved liver function. Without MDT, recommended for RFA, microwave ablation and TACE. With MDT, we discuss the cases and surgical input adds on good candidate for surgery. Radiologist gives a view, excellent image quality, no vascular invasion. Hepatologist, normal liver function, resection is optimal. So MDT recommendation is surgical resection. Outcome, a successful resection, no complication, disease-free, at least 2 years. So MDT favors curative treatment by changing from loco-regional to surgical approach, to surgical treatment. This is a case 2 transplant candidate beyond Milan. You have seen that the patient is 48 years old, SBSAG positive, child B cirrhosis, 2 nodules, 2 centimeter plus 1 nodule, 4 centimeter, no vascular invasion or extrahepatic metastasis. So without MDT, this exceeds the Milan criteria, so not a transplant candidate. But with MDT, when sitting together all the specialists, then the decision is changed, and there are other, say for example, UCSF criteria that allows 3 nodules to have transplant. So the ultimate decision outcome is successful down staging. And here is another thing, and by TACE we can successfully down staging the disease, and this has been ultimately listed for liver transplant and transplanted at 8 months. So a patient who was not recommended by a single physician for transplant, it has been decided for transplant by the multidisciplinary team. So you can see that the EASL, the BCLC, the Korean Liver Association, and Singapore Liver Association, and the American Association for Liver Disease all recommend the MDT approach and MDT guideline. So MDT is cost effective, it is better decision, better decision, fewer wasted treatment, more patient gets curative option, system becomes sustainable. So I have given some example, and effectively it has been decided that the patient gets better management with MDT. This is a fair access for all. And the key takeaway message is HCC needs many specialists, not just one. Multidisciplinary team improves survival and outcome dramatically. Team meeting standardize care quality. Bangladesh can do this with very simple resources. Tiered system, as I have already mentioned and shown, that system reaches all patients fairly. Even a village patient, a patient in the remote area can also communicate with the tertiary center. The future of HCC care is the future of HCC care is multidisciplinary and should be coordinated, is for everyone, should be available for everyone in Bangladesh. Let us start today, save lives for tomorrow. Thank you all for your patience hearing.